I recently came across a Valentine's Month luncheon for individuals who lost their loved ones. When I first saw the announcement, I thought, what a kind gesture. Thoughtful, human. I simply appreciated the compassion behind it. But on my drive back home, a question stayed with me. How many of those partners were lost to cardiovascular disease? Now, to be clear, not everyone in that room lost their spouse to a preventable heart attack or stroke. Some losses may have been cancer, accidents, or other illnesses. But statistically speaking, cardiovascular disease remains the leading cause of death in United States and globally. In the United States, one person dies every 34 seconds. That's nearly 930,000 deaths per year. So if you apply those numbers to any large group of adults who have lost a spouse, a significant portion of those losses were likely related to cardiovascular disease. And many of those events are preventable. About 1 in 4 US adults have elevated LDL-C above 130 mg per deciliter. This is where I believe our continuing dialogue about ASCVD risk prevention can make a significant impact. This isn't about debating LDL-C thresholds, memorizing risk calculator categories. It's not even about choosing one medication over another. It's about whether someone gets 10 more years of shared birthdays, anniversaries, and ordinary Tuesday dinners with a person they love. We don't need to chase immortality. If we apply prevention thoughtfully in the right patient at the right time with the right intensity, we extend healthy years. Welcome to LipidCurious, an educational platform focused on simplifying lipid management for clinicians. I'm your host, Dr. Vishnupriya Pulipati, a board-certified endocrinologist and lipidologist. This is part 3 of the ASCVD Risk Stratification series. Today, we'll cover 1. What treatment targets are we actually aiming for? 2. How to choose LDL-C-lowering therapies strategically. 3. What does the future of ASCVD prevention looks like? If you haven't listened to parts 1 and 2 of this series, I strongly recommend doing so. They make today's episode much easier to apply. And yes, this episode comes with a visual to follow. All right, let's get into it. Now let's step into our framework. This time, we are going to layer in clinical risk. This is slightly different from the 10-year PCE calculator risk. Clinical risk helps us apply treatment targets more consistently. In practice, we categorize cardiovascular risk into 4 tiers: very high risk, moderate risk, and low risk. So let's start with our 3 questions. Do they already have an ASCVD? Is the LDL more than 190 mg per deciliter? Do they have diabetes mellitus? If they have an ASCVD present, they are high risk already. If they have ASCVD with multiple events, recent events, or other systemic ASCVD risks such as diabetes, chronic kidney disease, or hypertension, then they are very high risk. Next, LDL-C more than 190 after ruling out secondary causes, they are high risk. If someone has just diabetes, nothing else but just the diagnosis of diabetes, they are moderate risk. If they have diabetes plus advanced in age, about the age of 65, longer duration of diabetes, have diabetes-related complications, or calculated PCE score is more than 20%, then they are high risk for cardiovascular disease. So in conclusion, if someone has an ASCVD, they could be high to very high risk. If their LDL is more than 190, they are high risk. If they have diabetes, moderate risk. Diabetes plus additional factors, then they go into high risk category. Now, if none of that applies, we are in the world of primary prevention, and we're going to start with the age. In children with familial hypercholesterolemia, we consider them high risk. Ages 20 to 39 with an LDL more than 160 and family history of premature ASCVD is moderate risk. But if you do the PCE calculator and you found a lifetime risk of more than 39%, then they are categorized in high risk. Ages 40 to 75, we use the PCE calculator. Remember the three numbers? 5, 7.5, and 20. So we categorized these individuals into low, borderline, intermediate, and high risk. Low and high risk words are self-explanatory. If someone is borderline and intermediate with the PCE calculator and they have risk-enhancing factors, then they are moderate risk. But you do a calcium score to identify further risk, and the calcium score is more than 100, they come into high risk. If the age is more than 75, then we usually consider moderate risk and we individualize based on the person. See, if you follow the framework and repeat it often, you won't need a table or a reminder anymore. So it gets easier as we practice this more often. Next up, what are we targeting? There are three practical markers: LDL-C, non-HDL-C, and ApoB. LDL-C represents the cholesterol mass inside the LDL particles. Non-HDL-C includes cholesterol mass in all atherogenic particles, including chylomicron remnants, VLDL, IDL, LDL. ApoB counts the number of atherogenic particles. ApoB is very powerful because the same amount of cholesterol can be packaged into few large particles or many small particles. Example, if I gave you 100 pounds of sand, right, you can put it into 3 large basketballs or 50 small golf balls. The LDL-C is like the sand inside these balls. The sand is the same in both of these basketballs and golf balls. The ApoB counts the number of balls carrying the sand. More particles, more opportunities for the endothelium to get damaged. So high ApoB level is a concerning factor. Now, there are only 3 LDL-C numbers you need to remember: 55, 70, 100. 55 for very high risk, 70 for high risk, 100 for moderate to low risk. Okay? Now, the hidden gems. Non-HDL-C is nothing but LDL-C plus 30. If the LDL-C goal is 70, then the non-HDL-C goal is 70 plus 30, which is 100 milligram per deciliter. Easy? Now next up, ApoB. When the LDL-C target is 70, ApoB target is also exactly the same, 70. Okay? Now, for the ApoB, very high risk is 60 is the threshold for that. If you flip the first number, it becomes a 9, right? So, the ApoB thresholds are 60, 70, 90. And the corresponding LDL thresholds are 55, 70, 100. Okay? Now, let's address percentage LDL-C reduction versus absolute LDL-C target. When the LDL-C is more than 190 or the calculated ASCVD risk is more than 20%, the guidelines did recommend an additional target of more than or equal to 50% LDL-C reduction. Why? Let's say someone starts with an LDL-C of 200 and you lower it to 100. That's a 50% drop. But more importantly, that's a 100-point absolute reduction. That is very meaningful. If someone starts with a 120 and you bring them to 100, that's only a 20-point drop, a different kind of an impact. The first patient, you removed 5 times more LDL from circulation. So what matters more, percent reduction or target? To be honest, both. If you achieve more than 50% LDL-C reduction and reach the LDL-C target, you can celebrate. That is ideal. But if you must prioritize and your arm is twisted, then the LDL-C percent reduction is especially more important when the baseline LDL-C is very high. It reflects the intensity and correlates consistently with event reduction. The target thresholds, like a specific number target, are critical in high-risk patients to ensure a sufficiently low atherogenic burden. So in practice, we try to aim for both when possible. Next, therapeutic strategies. For me personally, in my mind, it's easier when I simplify therapies into two big buckets: primarily LDL-C lowering and primarily triglyceride lowering. Today, we're going to get ourselves familiar with primarily LDL-C lowering medications. I think of them in the following orders: statins, ezetimibe, bempedoic acid, alirocumab or evolocumab, inclisiran, and in some special circumstances, bile acid sequestrants. Now, here's a practical tip for you. When you want a quick, accurate medication detail, I recommend going to your online search box and typing drug name FDA access. Example, bempedoic acid FDA access. You will get, the inserts you get inside the medication boxes that will be available. This one document in the first page will give you indications, doses, contraindications, side effects, cautions, drug interactions, the trial data they used, what did FDA approve. It's such an easy to look at document, and I find it more appropriate to follow. It simplifies even your medical documentation and prior authorization documentations. So this is evidence-based and efficient. For the next few minutes, I will talk about the approximate impact of LDL-C % reduction with these medications, okay? Step 1, lifestyle. Always foundational. This will give 5 to 15% LDL-C reduction. The American Heart Association suggests 8 essential components to a heart-healthy lifestyle: diet, physical activity, smoking cessation, healthy sleep, weight management, cholesterol control, sugar control, and blood pressure control. And I think I'm going to add on further to this, such as alcohol cessation, emotional well-being. They also contribute to a healthy lifestyle. Next, statins. These are first-line therapies for LDL-C reduction. They can reduce LDL-C by 20 to 60% depending on the type of statin you use. High-intensity statin options include atorvastatin 40 to 80 and rosuvastatin 20 to 40. Next, ezetimibe. This is oral, well-tolerated, and excellent add-on to a statin and quite underused, to be honest. This decreases LDL-C by at least 20%. Next, bempedoic acid. Useful in statin-intolerant individuals or when additional add-on therapy is needed. It can give up to 20% LDL-C lowering. Bempedoic acid and ezetimibe are available in a combination, and they can give a 40% LDL-C reduction. Next, PCSK9 inhibitors such as alirocumab and evolocumab are injectable monoclonal antibodies which can give 50 to 60% LDL-C lowering. Inclisiran, which is a twice-yearly infusion, can give a 50% LDL-C reduction. Lastly, bile acid sequestrants, which are not as commonly used these days, but they can give 15 to 30% LDL-C reduction, but they do have quite significant side effects though. I choose one of these therapies based on how much LDL-C lowering is needed and patient-specific factors. Next, the future of lipid prevention. This is where things get exciting. We are entering an era of earlier detection, precision risk refinement, combined therapies, long-acting injectables, and RNA-based approaches. But here's the truth. The future is not only about advances in pharmacotherapy, it's also about early intervention with existing therapies. We know atherosclerosis begins decades before events. We know cumulative ApoB exposure drives plaque formation, and we know earlier LDL-C reduction produces greater lifetime benefit. I believe we need to shift from reactive treatment after a cardiovascular event to proactive treatment based on the risk factors. So here are my take-home points. 1. ASCVD risk stratification only matters if it leads to an action. Know your LDL-C targets based on risk. 2. Treat in steps: lifestyle, statin, ezetimibe, and advanced therapies. Escalate intentionally. 3. Earlier LDL-C lowering for longer provides the greatest lifetime cardiovascular benefit. Now here's a challenge for you. With every lipid panel you review going forward, apply the framework, assign a clinical risk to the individual, set an LDL-C target, and choose a lipid-lowering medication. If you did like a companion resource, download the LipidCurious Starter Kit at www.lipidcurious.com and the visual aid attached to this episode. Thank you for joining me in this 3-part ASCVD risk stratification series. I immensely enjoyed the process of creating this. In 2 weeks, I'll be back with something different. Our first LipidCurious Inspiration episode, featuring a very special and inspiring guest. Before I sign off, a quick note. This podcast is intended for educational purposes for clinicians and healthcare professionals. It does not provide medical advice, establish a physician-patient relationship, or replace individualized clinical judgment. Thank you for tuning into LipidCurious. If today's episode was helpful, consider sharing it with a colleague. You can always reach me at hello@lipidcurious.com. Be sure to follow or subscribe so you don't miss what's coming next. Until next time, stay curious and stay confident. Signing off, Dr. Pulipati.